Well, no more twice daily injections.
Okay.
That's done with MDI and then pumps to keep the family in the driving seat.
Right.
But I also think time in tight range, because when that international consensus was taken, I objected together with Swedish colleagues and says, this is crazy. We should go for normal glycemia, time in tight range. And today, or yesterday, there was a lot of talk about this, and we know it's, of course, a very important question.
Right.
And you can say that life is never going to be normal again, but you need to find a new normality.
Right.
So in the way somebody said, okay, accept and then denial.
Right.
Because diabetes does not stop me.
It doesn't stop.
But you need to accept it.
Right.
And denial is good, because then you can still achieve your goals in life with diabetes on the side.
Right.
I think Johnny Ludwigson, he summarizes this very nicely. He says, it's no fun having diabetes, but you need to pay.
Welcome to Global Diabetes Insights, your go-to podcast for navigating the world of diabetes. I am Tino, a certified diabetes educator and a global advocate for non-communicable diseases.
And I'm Kona, a global advocate and a medical doctor. Together, we're your hosts, dedicated to raising awareness, fostering open discussions, and creating a safe space for everyone affected by diabetes.
Join us as we dive into empowering conversations with individuals living with diabetes, caregivers, healthcare professionals, and researchers. Our goal is to not only guide you through effective diabetes management, but also to inspire advocacy for proper healthcare access.
So get ready for a journey of insights, ideas, and diverse perspectives. Let's amplify our collective voice and create positive change. Get involved, get engaged, and join us in creating the change we need. So welcome everybody to Global Diabetes Insights.
So hello and welcome to the Global Diabetes Insights. And here I have the honor of delving into this amazing podcast session with one of the most respected voices. And I think I'd allow him to introduce himself to you.
Hello, my name is Ragnar Hannes, and I'm a pediatric endocrinologist from Uddevalla in Sweden. Joined my first ISPED meeting in 1988. I missed out only twice. One was because my father's 70th birthday, and one was because of visa problems. And during this time, I've been part of the steering. I've been both Secretary General and President.
Wonderful. So thank you so much. You're such a renowned person, well respected. You've written so many books, so many things have happened. You've been in the field for a while. Over the course of your career, you have witnessed immense advancements in type 1 diabetes management for children. Looking back, which single advancement has had the greatest impact in improving quality of life for people living with diabetes? If you may kindly share that.
Yes, I think that was when we started MDI, actually. Right. And we had a 4-year-old girl, 4 years. She was twice daily injections, and it didn't work well. We admitted her to hospital, took 125 glucose tests in 1 week, and this is back in 1984. And not one day was the other alike. So then I got some ideas from a Danish pediatrician, and I asked the mother about going for pre-meal injections. And she just said yes. So we took the risk together, because I had some experience in teenagers, but it was totally new in this young age group. And we invented an injection aid called the Insufflon, so they could give themselves injections through a port instead of direct through the skin. So thereby we solved the problem of multiple injections for the child during the day.
Right.
And that really changed the scheme, because then the parents themselves could understand what was going on, and they could adjust the doses themselves.
Wow.
So in 1985, we switched everyone to MDI. 70 patients, only one went back.
Wow. So this is amazing. You have come a long way, and you have witnessed a lot. Thank you so much for sharing that history. So people would get to appreciate people that are really still in this field. They began way back. They've witnessed a lot. There wasn't all this diabetes technology, all the things that are happening. So people had to manage with what was available then. But a lot has happened in the field, so which we'll get to anyway. So I think maybe the second question is on global disparities in diabetes care, the thing that you understand a lot.
But you also asked me about a frustrating thing that still exists. And what we did then was to put the parents in the driver's seat.
Right.
And what really frustrates me right now, we come to the global disparities, but so many high-income countries have a much too high HbA1c for their children.
Already.
And they have the resources.
Yes.
In Sweden, we know how to do it,
Right.
but it's still not done throughout the world
Okay.
in many cases.
Speaking of countries in the less resource settings, people don't have all the options that they need, so they need to just manage with what is available.
Yes.
It's another thing to have everything and making a choice to say, do I want to use it? But other people don't have that option, right?
Right. So that's why it frustrates me that you have the option, you have the money, but somehow it doesn't seem to work.
Yeah, it confuses us.
Yes.
Too.
That is very frustrating.
Wow, thank you so much for sharing that. I think maybe going on global disparities in diabetes care, there's someone who has contributed significantly. You have in diabetes care globally. How do you see the gaps between care in high-income countries and low-income countries in terms of what radical changes need to happen to these big steps?
So we have technology is helping us.
Yes.
So the first step is to go to MDI, which was done in the DCCTA study with NPH and regular and finger prick.
Wonderful.
I think that's the most important first step, because then you can make the family understand, change the doses, and they will be in the driving seat.
Right.
But in the next step of technology, it has been shown repeatedly that sensors are more important than pumps.
Wow.
And then I think like this, take Africa, for example.
Right.
You don't have any landlines for phones.
Definitely.
You went directly to mobile phones, just skipped the step of landline phones. And so I'm just waiting for someone to invent the very cheap CGM that can be used all over the world for the same cost as glucose strips.
Right.
Because that's really going to change the scene.
Yeah.
Then you will know what's going on, and from there you can slowly improve.
Definitely. To give an attest to that, because I've been using CGM. It's a game changer, totally. If people are to be given options, if you could use only one, either a pump or a CGM, usually people vote mostly for the CGM. But we all need them, right? If all the options are available, people can make the choice on their own, depending on how they want things to go. So thank you so much for sharing that with us. Maybe the next question that I have for you will be on technology in type 1 diabetes. With the rise in diabetes technology, pumps, continuous, like everything that you're sharing right now, I think, what do you believe is maybe the greatest misconception about tech-driven diabetes care?
With the hybrid pumps, I think auto is the greatest misconception.
Right.
And this depends on what you're aiming for. So if you're aiming to go down from 10 to 7.5 or 8, then auto is fine.
Right.
But if you're aiming for 6.5, auto is the wrong word. And I think we did that mistake, that we talked too much about auto to the parents, and they were then kind of out of the control.
Right.
So I think we really need to stress this is helping them along the way, but parents must still be in control.
Yes.
We have to teach them methods of how to have a good input into the auto algorithms and adjust them a little bit to their own child's need.
Right.
So they still need to be very active. And I think that's a take-home message for me. So fully auto is for maybe teenagers that are not motivated for anything.
Right.
Then auto works rather good, but we still need the parents in there. And also by doing that, you get the engagement. And the engagement in what happens around the child with diabetes, I think is really the very most important thing.
This diabetes technology, that's where even the parents can have access to this. They can actually see how things are happening. The approach that they would want to use would be different on how they want to support their child. If they are a bit of judgmental, then the child might not want to really open up. They might want to resist even to use this diabetes technology because they know that their parents are going to be watching. But of course, the parents are really needed. They're very key in this subject.
Yes,
so,
yes. And they get better sleep with the hybrid pumps. And that is a very important thing.
Definitely. Yeah, moving on the challenges in psychosocial care, beyond the physical management of type 1 diabetes, maybe deep psychological impacts for people, both children and their families. So what do you think is still missing? How we approach the psychosocial needs of people living with type 1 diabetes?
Yes, that's, of course, a very important question.
Right.
And you can say that life is never going to be normal again, but you need to find a new normality.
Right.
So in the way somebody said, okay, accept and then denial.
Right.
Because diabetes does not stop me.
It doesn't solve.
But you need to accept it.
Right.
And denial is good because then you can still achieve your goals in life with diabetes on the side.
Right.
I think Johnny Ludwigson, he summarizes this very nicely. He says, it's no fun having diabetes,
Yes.
but you need to be able to have fun with diabetes.
Right?
Yes, while you have diabetes.
Definitely. It doesn't have to control you. It's like a little devil on your shoulder. But you need to know how you can move forward with it.
Exactly.
Have a positive mindset. And then you can live well with your diabetes. Because the end goal is to have a good quality life. Whether you're seeing a dietitian, psychologist, endocrinologist, pediatricians, the idea is just to achieve a good quality life for people living with diabetes. And I think you've done so well, contributed so well in drafting the book that you did for Life for a Child. It's talked so much, it's so in plain language, even in the layman man can understand what you're trying to really talk about. And if it's the medical jargon, it was put in brackets. So I think you did an immense work. So we cannot thank you enough, especially in our end of the world, low to mid income countries. That book you've seen it mostly to be sort of like a handbook, like a manual. And I mean, it's still relevant. Things have changed, so many things are happening, but that book still serves, it still speaks volumes. And sometimes when you're just reading it, you'll be like in an hour of research to say, wow, this is amazing. But yes, a lot has happened and you've been part of this game changer. So we cannot thank you enough for that. Yes, we are here at ISPAD in Lisbon, and it's our 50th anniversary. You have seen a lot. You've been involved with ISPAD maybe since the inception. ISPAD's role and the future on this, I would want to understand, like you as a key leader in ISPAD and having shaped its direction over the years, what future do you envision for ISPAD moving forward?
Well, I think the most important thing that ISPAD does is the networking.
Yes.
Because I came to ISPAD as a very young doctor. I learned all kinds of things.
Wonderful.
I could listen to others, how do you do it? And then when I came home, it was a bit strange to begin with because there would always be one parent that said, okay, but we're already doing that.
Right.
And so I asked them, why don't you tell me? Or they said, we're not supposed to do that because we should do what the doctor says.
Right.
And then we changed that. So I tell them that, okay, your first year with diabetes is learning.
Right.
But then we learn back from you.
Right.
And that's the thing about ISPAD as well. You get the networking and you get friends all over the world that you can communicate with and you get good ideas. And the important thing, I think, is that good ideas are not only from north to south, so to say, that people who have a good standard can tell others this is the way to do it.
Right.
Because there are very good ideas from everyone.
Right.
And we can learn a lot from you cope with diabetes in Africa, for example. So I think that's very important. And then teaching. So we have the PETCA program, for example, in Africa for pediatric endocrinologists training in diabetes as well. And that has hugely increased the number from 2 peds endos to way more than 100 now. And ISPAD has a lot of these initiatives around the world about postgraduate courses, science school, etc., and the meetings. So I think it's a very important mission that we have. And the motto is so simple: a better world for children with diabetes. We're in it together, and we can learn from each other.
Yeah, this is so good. And I think ISPAD has been a bit of more of inclusive, especially coming up with a position statement that people use at school. It has a wide range, disparities. So many people from different parts of the world contributed to that. We had voices from all over the world. This is a global thing. We may not really speak for everyone, but we try by all means to reach out. Usually surveys are sent. People might choose not to respond, but it would be bad because we're in this together. It's not like people in Europe should be telling people in Africa what to do. We need to come up together, sit on the table, then discuss the standards of care. The standards of care in Sweden, in America, or in the UK cannot necessarily be the standards of care in Africa because we don't have the things you have access to.
Not yet.
Right? Yes. Maybe in the future we are going to have the same thing. We are hoping to see that happen. Moving forward, learning from the past mistakes. Every seasoned clinician, doctors, and even healthcare professionals, or even people living with diabetes or other allied healthcare professionals, has encountered moments of profound learning from mistakes or failures. So could you share a moment in your career where things didn't go as planned, and what crucial lessons you drew from those experiences?
Yes, that's important. I think it's one of the Chinese languages, a symbol for crisis and learning is the same.
Right.
Something like that. So from every episode like that, you can learn things for life. Especially remember when I was in training, I had this child with gastroenteritis. She seemed to be doing quite okay, so I sent them home. 2 days later, I was on duty again, and they told me she's in the ICU.
Right.
Oof, I felt very bad about this.
Oh, sad.
But I said, at least I can go up to the parents and apologize.
Right.
But I didn't get to that because as soon as they saw me, they said, thank you for telling us to come back immediately if the child is doing worse. So they had seen another side that I was not really aware of, that I actually had conveyed to them the message that you're welcome back if the situation changes. And I actually shared my view of the current situation with them so they could see that there was a change to the worse and they came back.
Wonderful.
So that was very good for me, a learning experience. Always be honest with the families, tell them how you think,
Yes.
how you judge the situation,
Yes.
and then you can share decisions.
This is so good. And I think yesterday also I learned in one of the sessions that I attended when one of the clinicians was saying, when you're talking about sharing experiences, like you said, like ISPAD provides that, like some of the doctors were saying, in the US, the way we do offer care to our people living with diabetes, it's like we are suggesting. We don't tell them you need to do 1, 2, 3 things. We need to be suggesting. People living with diabetes, they need also to share like parts in decision making for their care.
Oh, yes.
Yes.
Very much.
Otherwise, they might not want to do it because they're telling them what to do. You don't understand how they're living, how they've been impacted, because probably maybe people with diabetes are only coming into the clinic to see you, but maybe once a quarter. They are involved more, so they need to be part. And then you as a clinician need to guide them to say, okay, fine, this is how you do it, to interpret everything so that they can always come back to you.
Right? And it's very important that the family is in the driving seat.
Right.
But sometimes you need to give them, say, an offer that you cannot resist. So the parent takes the decision, but in a sense, I've already told them so much what I think that they will think the same way. From the onset of diabetes, I think that's where we define our targets together with the family. And at that time, to go for normal glycemia, timing type target is not a problem. Target HbA1c of 6.5% or 48 millimoles is not the problem either if you just share your background and views for this with your family.
Thank you so much for that, Dr. Ragnar. From your legacy, you have done so much and you're still eager, you are still contributing, you still want to go far, and you're humble, working with even young people living with diabetes, young healthcare professionals who still have a lot to learn from you. What do you hope will be your lasting impact on the diabetes community, particularly for the next generation of pediatric?
Well, no more twice daily injections.
Okay.
That's done with MDI and then pumps to keep the family in the driving seat.
Right.
But I also think time in tight range, because when that international consensus was taken, I objected together with Swedish colleagues and says, this is crazy. We should go for normal glycemia, time in tight range. And today, or yesterday, there was a lot of talk about this, and we know that it's coming.
It is coming.
And the 6.5%, the target was taken in the UK first.
Right.
And then we thought about this, must be impossible, we said in Sweden, but after 2 years, we had convinced ourselves. So in 2017, we changed to 6.5%.
Right.
And I was part of that group.
Wonderful.
Which is, I think, feels very good. But then also that, what I mentioned, the pain relief, the port that it's just like a pump port, but you put a needle into it. That's a good beginner step for pain relief for young children.
Thank you so much for that insightful conversation and also being part of all this decision making, trying to voice your opinion. I might not just have to say yes, even the United States are doing it, or these big people in the field are saying it is correct or it is supposed to be done. You also need to really learn from your own experience. How can we just move from time in range to time in tight range? People in Africa mostly, or in the low to middle income countries, they don't really know anything about time in range because they are still yet to learn about HbA1c.
Yes.
How can they talk about time in range when they don't have access to the CGM, for example? So we only get to talk about all these things like if we know where are we going, where we're coming from. So we need to understand every step of the way and be part of the decision making. We need to be informed about the decisions that we are making. So networking is good so that we learn how they managed to do it. So I know that like today we will have a networking event. So people are just going to be talking and chatting on how best they can improve care for people living with type 1 diabetes around the world. And maybe moving forward, I think we're heading to the end of our session. So I know, yes, there's a lot of talk in the diabetes community from your own opinion. So we know, for example, from low to carb advocates to debates on insulin types and ethics on imaging treatments. So is there a particular controversial stance you hold that might challenge the conventional thinking? And how do you see it shaping the future conversation?
Well, when we started with MDI in 1984
Right.
and then 85, that was very controversial.
Right.
No one in the US was using it at that time. Just about no one. We had pump schools for European colleagues. We started with pumps in 1984. And so MDI and then early pumps is a very important change in the future if you can afford the pumps. But
Right.
MDI is the first step
Right.
if you're on injections. I think I cannot enough stress that because I know a lot of children around the world are still on twice daily.
Yes.
And they can, even if you only have access to NPH and regular, you can manage MDI if you get some blood strips. And then we mentioned the target, but something for the future, I think, early treatment for complications, preventative treatment, like treating hypercholesterolemia a bit earlier than we do today. It's said that the target is 2.6 or 100 milligrams per deciliter, but we're not allowed to treat until it's 3.4 or 130 milligrams per deciliter. And there are different opinions about early treatment. But still, we know from old data that the mortality in diabetes went down before HbA1c went down. And that was because of blood pressure treatment and statins.
This is huge. So thank you so much for your attention to detail, being able to disclose all these issues and ranges, the numbers. This is thought-provoking. So thank you so much for that, Dr. Ragnar. Maybe on the future of insulin. Yes, insulin was this more than a century ago.
Yes.
But we're still having issues to do with access, affordability. As a person who has been involved in this field for more than 3 decades, in your view, how can the global community overcome this barrier and what innovative solutions should we be focusing on?
Well, I'm a bit surprised about the pricing of insulin,
Right.
because if you take other generic drugs, like statins, they cost just about nothing today. But it's because they are called now biosimilars, and the procedure of making them is rather complicated. When the patents went out, they expired. The companies started making copies of each other's drugs instead of generic copies making very cheap insulin. So I think we should look more into, like India, for example, has a huge drug industry. I think Bionic is the name. We shouldn't mention any names here. So there are other companies that probably could produce insulin cheaper. It should be possible to put a price cap on insulin.
Right.
For me, it's cheaper to buy insulin in Sweden than on the street in Nairobi because there are so many middlehands. And so you need another distribution system, I think, to make it affordable for everyone.
Thank you so much. I think, yes, it's a reminder, a call to action for people living with diabetes who are really impacted by this with the cost of insulin. Because for me, I cannot just move from Zimbabwe and say I want to live in the United States. I need to be able to calculate, will I be able to afford insulin? Because even citizens in the US, they also complain that the prices are insane. The co-pays is just way too much. So imagine it for someone who is maybe a foreigner who wants to live in the country. It will be a huge blow for you because you need to pay for everything.
And this has been up at a very high political level.
Yes.
And I think the price recently has come down in the US,
Wow.
both by the two big companies.
Wonderful.
Sweden has a public tender system, so it's impossible to increase the prices too much.
All right. Yes, I think even for me, living in Zimbabwe, the prices of insulin have never really gone up since my diagnosis in 2010. It's been the same.
Yes.
So thanks to those who make the policies to say medication should not be taxed, which it should not, because it's a human right. We need to have it. But we are still trying to demand how best we can work together. People should be able to afford this. People should be able to access this for free. Because if you don't have money, it doesn't mean that you have a right to your health. Let just maybe the same way we responded to COVID-19 to say people were being encouraged to use vaccine, to get vaccinated. And some were saying, no, we don't want it. All that could actually be translated to say like on how we approach to these non-communicable diseases because they are there for life. We don't know if the cure is going to come in our generation. Yes, of course, advances to treatment, novel therapies have been discovered, and we're still discovering so many others. We don't know when this will happen. And even doctors were saying, I used to say, maybe in 5 years we're going to have a cure. But it's been like 30 years since then. It's mind-blowing.
When I started with diabetes in the early 80s, they said islet transplantations are coming soon.
Right. How soon is soon?
Yes, within 5 years, they said.
Yep.
And still it's not clinical practice.
Oh, yes. Wow, thank you so much. And maybe the last question that we have for you and I, we are both part of the ISWA 2025 conference committee. So how do you envision the future of pediatric endocrinology beyond the clinic?
I think to improve care, we have a low-cost model which is available to everyone. And that is having national diabetes registries with open benchmarks. And that's really a low-cost solution. But seeing what your friends are doing in the same country, in other countries, knowing who to go to for good ideas, and just seeing your numbers up there, it's been very powerful in Sweden. I think that's the single most important issue behind our success. And it's very easy to implement. And then you can have 6.5, maybe not as a target, but a fact.
Right.
That this is a fact that the lower you go, the lower is your risk for complications. And actually that's how, when the UK did this in 2015, they had a parent on the committee and they were showing all these slides on DCCT. So the parents asked, are you telling me that 6.5 carries a lower risk of complications than 7? Yes, they said. Oh, wow. She told them that that's not a target to me, that's a fact.
Right.
And you need to tell this fact to every family with diabetes. And that's exactly what we did when we implemented 6.5 in Sweden.
Right.
And the families just said, okay, that's it.
It's an interesting thought, like that you're just bringing it that close. Yes, for people living with diabetes, yes, they may need to understand that having complications, it doesn't really mean that you're doing bad in your management. Maybe it's because of the time you got to diagnose yourself.
Yes.
Which people didn't know so much about. People should not be blamed. They should not feel ashamed. If I have complications, then I cannot go to the hospital. Maybe I'm reaching to the end of my life. But we need to manage all those kind of conditions. If people have, it's inevitable for people with diabetes to develop complications, right? So, and also, but if you're managing it well, if you have a good quality life, you can delay those onsets for those complications, but they will come.
And then target setting in your country, for example. If I say your target should be 6.5, you would say that's almost impossible.
Yes.
But then I think we need type 1 TID index, because then you would have another level of what is usually achievable with the standard of care that you have. And that is one level. So that would be the target. But then 6.5 would be the fact. And for you, having diabetes, you would need to know both.
Right. Our doctors in our own countries, usually they are using the standard that you're setting in Sweden, considering the options that you have. So if they are to implement or to say, people in Zimbabwe, you need to achieve these standards without the CGMs that you have access to, there's a huge gap. It's nearly to impossible really to achieve such, because there'll be so many high. If you don't have access to strip, if you cannot test your blood sugar levels, and if it goes below 3, you don't have hypo unawareness. So how will you be able to know what to do when if you don't have these things? So I think our doctors or medical professionals should also be attending these conferences so that they can learn how these things, where you are coming from, and how you got to decide to say 6.5 should be good. Why should they be saying that? They need to know where this is coming from.
So I think it's good to tell someone that with current access, you're doing fine with 7 or 7.5. You're doing a good job.
Yes.
But to be honest, we have to tell them also that you still run a risk.
Yes.
And what happened before we lowered the target in Sweden was that we had families with 6.0, for example.
Wow.
And at one time they would be kind of scolded by the diabetes teams. Too low, too much hypoglycemia risk. And the family didn't have that.
Wow, really?
So we should learn from families.
Yes, learn from families.
And as long as no hypoglycemia problems, not too much of family burden.
Perhaps we need now to be seeing family involvement or parents getting also to share, like maybe at workshops in these diabetes conferences where parents are given an opportunity to speak, to share their experiences because they know so much.
And also Facebook groups.
Yes.
We have a very strong Facebook group in Sweden for parents with diabetes.
Wow, this is huge.
In the for parents to children with diabetes.
Right.
Yes, and it's amazing to see what they write to each other. So there's such a strong support and also good advice.
Right. Thank you so much, Dr. Ragnar. And I don't know, like, if you have any last words to the audience.
Well, I'll just keep up the good job. We do things step by step. And when I see numbers on HbA1c, for example, I always look at the slope. So it doesn't matter where it is to begin with, but is it going down? That's fine. Is it stable? It's going up. That's really not good. But you have to begin somewhere.
Yes.
And we started early in Sweden. So that's why we're currently ahead.
Right.
But you're going to catch up with us eventually.
Definitely, we hope so. So thank you so much, Dr. Ragnar.
Well,
This has been amazing. With all being said, we'll rest our case. So thank you to our audience. Yes, stay tuned for more that will come, and these are the people that will be bringing, the people that we love to be bringing to you, so that you learn from them, because they've been in the field for almost more than 4 decades. So which is so good. We have a lot to learn, and the future is bright. So